Estoy contenta de estar aquí con vosotros en Sevilla y que las dos sociedades trabajamos juntos ahora y espero en el futuro. Hello, everyone. So that's enough Spanish for one day. I'm going to be talking about polytrauma, and rather than talking about the whole of polytrauma from head to toe, I'm going to focus on abdominal solid organ trauma, specifically the liver, spleen, and kidney. And what I'm going to try and do is to help you to kind of work your way from just simply being descriptive to really helping the trauma team work out how they're going to manage the patient. So we'll start off with the liver, and the liver is obviously the kind of most complex thing and the one that we'll spend the most time on. So a very, very good starting point is something which I'm sure you're all familiar with, which is the AAST grading classification system for liver trauma. And when you look at this, we kind of all look at this when we're on call, don't we? You look at the grading system and you look down, and basically this is all about presence of hematoma or laceration. So let's look at some examples. So here we are, we've got a kind of small laceration, it's grade 1 laceration. Here's someone who's got a much more extensive laceration and hematoma, so you're kind of getting towards grade 4 type liver injury. That's pretty straightforward. I would personally actually add on to the hematoma and laceration devascularization, and I'll show you what I mean. So here's a patient who was stabbed, and you can see where the knife wound has gone in, there is definitely laceration and hematoma. But then when you look more distally, there's this region of devascularization as well. And actually, it's often quite hard to work out where the devascularization is. So if you use the portal phase imaging, or sometimes even you can't see it on the initial imaging, you see it on the 48-hour CT, that will help you to identify the devascularized area. But the problem is that you can write a beautiful description of what you see, and it really doesn't help the surgeons that much. Really, they want to decide how are they going to actually manage the patient, and they've got 3 options. So they can either manage the patient conservatively, or they can manage the patient with surgery, or they can call us up and say, please, can you help us with interventional radiology? Now, the first thing that they're going to do is they're going to decide on a clinical setting, which is whether or not the patient is stable or unstable. And obviously, that is a clinical judgment. But if the patient is stable, that's where we really come into play. So if the patient is stable and we see that there is active bleeding, then we can really help them out. If there is active bleeding and it is arterial or venous, then really the patient is going to go down different management pathways. So if there's arterial bleeding, they will certainly go to interventional radiology. Whereas if there's venous bleeding, there's nothing we can do about it because they're just going to bleed and bleed and bleed, and they're going to need to go to surgery eventually. The other area where we can really, really help as radiologists is being aware of the fact that people are at risk of developing future bleeding or developing ongoing bleeding. And so we need to be alert with the clinicians and kind of saying to them, look, hang on a second, this patient needs to come back for another CT, and we need to say to the clinicians what the time frame is for when they need to come back. So it's everything in this yellow box that we're going to be talking about. It's everything in this yellow box that we as radiologists can make a difference. So let's explore what we mean by active bleeding or the risk of further bleeding a little bit more. What should we be looking for? So what I do whenever I look at an image is instead of kind of passively looking at an image, I try and ask myself questions and interrogate the image. So what I'm looking for is capsular breach. So if I see hemoperitoneum or the capsule clearly disrupted, if I see vascular damage, so either contrast extravasating out, or maybe a pseudoaneurysm or an AV fistula, and if I can see that the laceration has gone to the porta, that's a bad sign. And I'll put that kind of checklist of 3 things up in the corner of every image that we look at. Okay, so here's our first patient. He was in a road traffic accident. He's stable clinically. And here's our checklist in the corner. This patient did not have a hemoperitoneum. And if you look at the hematoma that you can see that the capsule is still intact. So it's elevated, but it's still intact. So this is a contained subcapsular hematoma. There's no hemoperitoneum, as I say. It's a grade 2 injury. So and what I'm going to get you to do now is to vote. I'm really hoping that the voting system is going to be working. So I'm going to get you to vote now and tell me, how should this grade 2 liver injury be managed? So you're going to have to tell me, how do I set the voting up? You're going to choose between the options: conservative management, repeat CT in 48 to 72 hours, interventional radiology, or operative. Do I have to press anything else, Milagros? Or is everyone voting already? What do? I go to results, do I? Okay, thank you. There's nothing like me knowing exactly how it works, yeah. See results. Oh, great. Perfect. Okay, good. So everyone voted B. And then what do? I just come out of this? Close like so. Thank you. Okay, good. And then we keep going. Okay. Oh, repeat CT. Interesting. Okay. So yeah, so that is an interesting answer. You could repeat the CT, very conservative way to do it. So basically, either this patient needs no further management, or you could repeat the CT. I think it's reasonable to repeat the CT. But this is a very contained type of hematoma, and really it was outside of the liver parenchyma. Okay, next patient is a patient who was hit by a car. They're a polytrauma patient. They had multiple injuries. And they've got hemoperitoneum. So this is the first image I'm going to show you. The fact that they've got all of this hemoperitoneum, which was coming from the liver because there was no other intra-abdominal injury, is a bad sign, isn't it? It's a sign that they've got capsular breach. And then when we look at the liver itself, you can see that the laceration is going all the way to the porta. So that's another kind of significant sign, isn't it? That there's quite a significant injury of the liver. Okay, so this is a grade 5 liver laceration. So we're going to vote again, please. How should this liver injury be managed? You've got the same set of options as last time. Should they have conservative management? Should we repeat the CT in 48 to 72 hours? Should they go to hepatic angiography? Or should they go straight to operation? And you can vote now, please. How are we doing? I'm going to go to see results. Let's see. Okay. So most people going for operation, which I agree with. Let's go to the next slide. Yeah, so this is operative management. This patient is not going to do well with conservative treatment. So they went for damage control laparotomy and packing. So what happens is the surgeons take them to theatre, they pack the abdomen, do a kind of quick operation, stabilize the patient, and then they plan to go back later on. And this patient will not settle. Okay, another patient here. So this patient was hit by a car. They're clinically stable. Here's the arterial phase image. And on the arterial phase image, you see this little blush of contrast. Now, I think this is a pseudoaneurysm. And the reason why I think it's a pseudoaneurysm is because on the venous phase, we can see that that fades. And we can also see that there's a kind of devascularized area around it as well. Okay, so you're going to tell me again how you think that this patient should be managed. I'd like you to vote now and tell me, same options. I'm not very imaginative with my questions, they're all the same. Conservative management, repeat the CT in 48 to 72 hours, interventional radiology, so hepatic angiography, or operative management. And I'm going to, if I go back like that, so you can just take a quick look at the image while you're voting. Can you still vote? I have no idea. Okay, I'm going to go back to see results then. Let's see. Excellent. Okay, this is all working beautifully. So, this patient is stable. That's the most important thing. If they were unstable, they'd have to go to surgery, wouldn't they? But they've got active bleeding, and it's arterial. It's a pseudoaneurysm, and so they are a candidate for interventional radiology. And therefore, as you have all correctly chosen, they should have angiography. And here's the angiogram, and actually that pseudoaneurysm is so much bigger on the angiogram than it was on the CT, isn't it? And here it was successfully embolized. Okay, here's a different patient. Now this patient is unstable, and they've had blunt trauma, and I put the arterial phase images on the top and the venous phase images on the bottom, and you can see that there is this blush of contrast at the top, and in the center, and then around it a region of devascularization. Okay, so how are we going to manage this patient? They're unstable. Well, luckily you can relax at this point. I'm not going to make you vote because it's exhausting. This patient's unstable, so therefore by definition they have to go to surgery. Okay, but because they've got that blush of contrast, we may have a role to play as interventional radiologists. So we could either help at the time of the operation, before the operation, after the operation. And we know that working as a team with the surgeons, we can really decrease the morbidity and mortality of these patients. So it's about working together as a team. Okay, here's another patient who was hit by a car at a very high speed, and they're very unstable. I'll show you the portal phase imaging. So basically, the whole of the left lobe of the liver is completely wiped out, and you can see that there's a laceration of their left hepatic vein. So it's actually gone almost all the way down to the IVC. So it's a venous injury here. Obviously, there's a hemoperitoneum as well. Obviously, it's extended down to the porta, so this is a quite significant injury. It's a grade 5 laceration, really. So let's think about how we're going to manage this patient. And again, I'm not going to get you to vote, but just to think about it, how might you manage this unstable and shocked patient? Well, they're unstable, so they have to go to surgery, don't they? But I showed you that they had a venous injury, and because they have a venous injury, that is yet another reason why they need surgery rather than anything that an interventional radiologist might be able to do. Okay, so venous injury equals surgery. Now, finally, before we move off the liver, let's think about follow-up. So it's very important to follow these patients up because of the risk of developing a pseudoaneurysm or an AV fistula, which is what I think you were all thinking about with the first case. So do you remember that man who was stabbed in the beginning and he had that devascularized area? This was his initial CT, no pseudoaneurysm or AV fistula there. But then when we followed him up kind of 48 hours to 72 hours later, as we should have done on our algorithm. Here he is 2 days later, and you'll notice that he's got this blush of contrast. You can see it in the arterial phase, and you can see it in the venous phase. And this is actually an AV fistula between the right portal vein and the right hepatic artery. So you have to follow up all of these patients. Here's another patient. Now, when he came in, he had a CT done very, very quickly before he went to theatre, which was essentially normal in terms of there was no pseudoaneurysm. It was very abnormal in terms of his liver injury. Here's his CT 2 days later, and he's developed an enormous pseudoaneurysm at the site of injury. And again, you can see on the angiogram an enormous pseudoaneurysm which was successfully embolized. So what's the risk of pseudoaneurysm? It's about 4%. And the strange thing about the risk of pseudoaneurysm is it doesn't really seem to be proportional to the grade of liver injury. And it doesn't actually seem to be more common in blunt or penetrating injury. It just seems to be a little bit random. And so the learning point is you really do have to follow up all of your liver, spleen and renal injuries, in fact, because these people will be asymptomatic until they're suddenly not asymptomatic. And basically the risk of bleeding eventually is high. Okay, so let's move on to the kidney now. And the kidney has the same grading classification as we see before, so it's all about the hematoma and the laceration. So you might see a small laceration as we see on the left, or you might see a big perinephric hematoma as we see on the right. But that's not very exciting, is it? What's really exciting is thinking about what goes into the kidney and what comes out of the kidney, so the vascular pedicle and the renal pelvis. So let's think about vascular injury first of all. And here's a patient who fell 2 stories, and you can see complete lack of enhancement of the left kidney. And that is because they had dissected their left renal artery. And obviously there is a risk there that dissection at some point will start to bleed. Here's a different patient who's got a grade 5 renal laceration. A good tip is to actually reconstruct the renal artery in the coronal plane because it's easier to see active bleeding. And we can see active bleeding here coming from the superior renal artery. So how should this patient be managed? I'd like you to vote now, please, and tell me. Same set of options: conservative management, repeat CT, interventional radiology, or operative management. You can vote now. And let's see what the results are. Okay, a mix between D and E, I think. Now I have to remind myself. D and E, there was no E. Must be D. Maybe it was C and D. C and D, thank you. It would be good if I could spell. Okay, thank you. Okay, yes, so anyway, this person had angiography, and when they had the angiogram, you can see much more clearly where the active bleeding is, much more clearly than you can on the CT. Now, next patient had a crush injury, and here we can see that there's this big hematoma around the kidney, and you don't have much normal-looking kidney left. And the learning point here is that you often don't see active bleeding very well on CT. It doesn't kind of come out and wave at you. And so when we look here, you have to ask yourself that question again. You have to interrogate the CT. What's happened to the superior renal pole? And kind of you have to, again, look along that renal artery, and you just start to lose the superior renal artery. And it would be easy to dismiss that, wouldn't it? But in fact, when you compare you don't have to vote on this question, don't worry, and it's the same set of questions. But when you actually compare the angiogram with the CT, once they started to select the renal artery, and then they kind of super-selected the renal artery, and super-selected the renal artery, actually there's a huge lot of bleeding coming out of that superior renal artery. So it's all kind of hidden somewhere in that great big perinephric hematoma. So you've really got to think quite hard about what is going on in that perinephric hematoma, and that will keep bleeding. You can't just kind of rely on it tamponading itself. And again, that was successfully embolized. Okay, so we thought about the blood supply in. Let's think about the renal pelvis coming out. When you see a laceration that goes all the way to the renal hilum, and then you see soft tissue density around the kidney, you must measure the Hansfield units because, of course, it could be a urinoma. And if this patient is stable, then you can keep them on the table, as we discussed earlier, and then you can demonstrate that urinoma because you see contrast within the urinoma. So remember to do that delayed phase if you can, if you have the presence of mind. So these patients can be managed conservatively. Those urinomas will just settle with time, which is good to know. Sometimes, though, remember that once the ureter has been breached, then you can get clot in the ureter. And if you get clot in the ureter and then that causes obstruction, the patient then obviously is at risk of problems. And so you need to kind of start monitoring that patient. So here's someone who was stabbed in the kidney, and they then developed a clot in the left ureter a couple of days later. So you can see the abrupt cutoff in the left ureter. And if we look on axial imaging, see that filling defect in the left ureter. So you have to keep an eye on that patient because potentially they may end up needing a nephrostomy. Okay, so finally, let's move on to the spleen. Okay, so we're back to the same grading classification, aren't we? It's hematoma and laceration and kind of same description, really. So here we are, we have a small grade 1 laceration of the spleen and then a bigger laceration with some hematoma around it. That's all fairly straightforward. But with the spleen, really, it's almost exactly the same as the liver. You're thinking about whether or not the patient is stable or unstable, and you essentially have three management strategies. They can either be treated conservatively, or they can be treated with interventional radiology, or they can be treated with surgery, and you're working with a team to help them work out how to treat the patient. So you're helping them to work out, is there active bleeding, are they at risk of further bleeding, and kind of keep an eye on them all. So it's that same kind of strategy and the same yellow box that we were really talking about before. So you'll be asking yourself those same three questions when you look at the film. Is there capsular breach? Do you see any evidence of vascular damage, including active bleeding, pseudoaneurysm, AV fistula? And has the laceration gone to the hilum? Same three questions. So here we are. So here's a patient on the right side, and this patient has got a laceration which is going closer towards the hilum, not actually towards the hilum, but the splenic capsule is actually preserved, and there was no hemoperitoneum. So actually this patient also managed to have conservative treatment. What about this man? So this man was stable, that was the good news, even though he'd fallen from a couple of stories. But he had a quite significant splenic injury, and I'll show you this. So let's look at the arterial and the venous phase imaging here. First of all, you'll appreciate that he has got quite a significant hemoperitoneum, and the laceration is definitely going to the splenic hilum. And then when we look at all these kind of big blushes of contrast, he's got some pretty impressive active arterial bleeding. So where is he on this algorithm of ours? Well, the good news is he's stable, but he's got active bleeding, hasn't he? So he's got arterial active bleeding. He's a perfect candidate for interventional radiology. And so he had embolization. You can see the multiple bleeding points when he went for embolization. So they embolized him, and a few days later he came back for his follow-up CT. He's still got nice residual splenic tissue, and that might mean actually that he's got reasonably preserved splenic function, which is obviously good news for him. Last patient that we're going to look at. So this little boy had a kind of innocuous injury when he fell over his handlebars, and I'll show you his CT. So here we are, and I'm not going to give you any kind of commentary about what we see, because this is your last question. So, what are the findings? It's grade 5 splenic laceration. What are the findings and what management should you choose? You only have 3 options. Is it that there's active bleeding? He should go to interventional radiology. Is it that there's no active bleeding? He needs close observation. Or is it that there's active bleeding and he needs splenectomy? So do you want to vote now, please? And would you like to look again, or are you okay? No. Okay, you can vote now. Let's see. Oh, everyone chose C. Fantastic. Okay, good. Okay, so the correct answer is active bleeding for splenectomy. So if we compare the arterial and the venous phase, even just between those 2 phases, which are kind of less than 20 seconds apart, really, you can see how the contrast spurts out between those 2 phases, which is a sign of how much bleeding is going on with this poor kid who's so unstable. And in this situation, really, for multiple reasons, there is no role whatsoever for IR. He has to have a splenectomy, doesn't he? So really, what that kind of tells us is that, to remind us that, okay, splenectomy definitely has risks. The mortality and the risk of infection is definitely higher, both in the short term and in the long term. But embolization itself is not without risks. In fact, we mustn't forget that there is a risk of abscess formation in the residual spleen in the kind of days and weeks after the splenic embolization. So the final thing to say is that when you're following people up who've had a splenic injury, if they still have a spleen, then you definitely need to follow them up. So the first thing is they obviously still have a risk of developing a pseudoaneurysm or an AV fistula. So just like with the liver, you need to do follow-up CT within about 72 hours. And then in the post-embolization patients, you need to follow them up at about 6 weeks, because you need to be looking for the risk of abscess formation as well. So those are the 2 things to remember with the spleen. Okay, so what are our learning points for solid organ injury? You've basically got 3 choices for the solid organs. You can manage people conservatively, you can use IR, or they need to go to surgery, or you could use a combination of all 3. Obviously, unstable patients are going to be treated operatively, but there's a really good role for interventional radiology with arterial bleeding. Remember that when you have renal injuries, you should think about delayed phase imaging, especially when the patient is on the table. And never forget about doing follow-up imaging for patients for pseudoaneurysms and AV fistulas. And that's really our primary job as radiologists, because the clinical team may not be thinking about that. Now, what I'd like to do is to remind all of you to come to the next ESER meeting, which will be in Brussels next year. And particularly, I would like to invite all of you to think about applying for the European Diploma of Emergency Radiology. I'm delighted to say that we already have 2 Spanish holders of the European Diploma of Emergency Radiology, and I'd like to see many more of you doing so in the future.